Yes, hello, welcome here at the workshop about hamstring injuries. It's for me a pleasure to be here to give this workshop together with Anna, my colleague in also the AMC hospital. A workshop is always challenging, but we will try to make it a workshop that you also have to do something and maybe learn some clinical stuff also with your hands. The next challenge is that we have here in the audience very experienced guys and girls about hamstring injuries and people who probably not very experienced in hamstring injuries. We hope that we can provide some new stuff for you all. We will focus on the prevention part, because talking about hamstring injuries we can fill up a whole congress, but today we will do some about the prevention part. Why hamstring injuries? Because it's, I think, the biggest problem in a lot of sports. If we look at the data, for example, in football has a lot of injury data. You see the hamstring injury in this picture on the right side. No. And also, if you have very good eyes, you see that the color yellow behind the hamstring injuries is the most clear. And the yellower it is, the bigger the problem is for this specific sport, because it means it has the very high frequency, so it's very common to occur, but also what we call the burden, how many days players are out of their matches and training, and is for hamstring injuries the biggest issue. And it also leads to the biggest costs in professional football. So if I talk with some financial guy from a football club and I give him the question, what do you want to get rid of in your club, hamstring injuries or ACL injuries? What would the financial director say if he see this picture? Hamstring injuries. Yeah. If I ask a patient, what would you like to have, an hamstring injury or an ACL injury? Of course, I would rather have an hamstring injury than an ACL. But if you look at the complete picture, it's the number one injury in sports like football. And in other sports there's less data, but you can remember if there's a lot of sprinting, a lot of acceleration in sports, then hamstring injury is usually in the number one or within the top 3 of injuries. That's why we're here. Okay, question for you guys. Who knows why we call it hamstrings? What is the origin of this term? Hamstrings. Nobody ever thought about it? People who have an hamstring every day on their huh? It's a long tendon. Yeah, so that's the strings. Yeah. Yeah, correct. It were the strings where they hang up their ham. So that's why we call it the hamstrings. Okay. So it's just, if you have a chat with a patient, then it's always nice to know this, huh? Huh? Yeah, yeah, yeah. I'm not sure if it's good to compare a patient with a pig, but okay. So for this talk, I want to make sure that all people know that the hamstring is a muscle group. It consists of several muscles, and if we look at prevention and also the content of this talk, I want to know that we can divide it in 3 main muscles. So let's see how's the colors here. Yeah, in red we see the biceps femoris, that's the hamstring muscle head on the lateral side, and on the medial side we have the semitendinosus and the semimembranosus. Is it important? It might be important that there are it's just not just one simple muscle, but it contains of several muscle heads. And of course there's also a short head of the biceps femoris, but for injury prevention maybe less relevant, at least for this talk. So what will we discuss today? We will talk about hamstring prevention, and we'll discuss the classic way of doing hamstring prevention. What's new, the new, and that's why I brought Anna. He will talk about the evil twin. The classic. Who is familiar with the Nordic hamstring exercise? Who never heard of it? Okay. Who ever did it himself? Okay. So the people who did not do it, they have to do it in several minutes. So this is a good example of a very effective way of injury prevention, because what we know from studies already Now in 2011 there was the first randomized controlled trial, but I heard from my colleagues in Norway that even in their books that were written like 50, 60, 70 years ago, this exercise was already there for injury prevention of hamstrings. What we see approximately doing this exercise with a certain program can reduce your risk on a hamstring injury by approximately 50%. In my profession, there is no intervention that is more effective than this one. And even in this one, there's a lot of debate. If this is this the best, is this the only way? Okay. Okay, but the Nordics, we're on a workshop. So we show one, and then the people who never did it at least have to also try it. And okay. My family in Dutch, they called us also the familie Scheuring. Looks easy. Okay, who did it never do this exercise? I saw one. You want to try it? Who wants to try it? Nobody? No? Oh, this is going to be a difficult workshop. How get I display? Play.
Spatiebalk misschien?
I want to discuss this exercise. Looks very easy, and one of the problems with it is that people often don't do it because they need someone else. Oh, no, you don't need someone else. Oh, we have a PhD now doing his research on this exercise as injury prevention for re-injuries. You can do the Nordics everywhere, but still, this exercise is not done by a lot of people. Why not? Who can tell me why athletes don't do this exercise often? It hurts. Yeah. High risk for injury. Okay. Yeah. Well, why? What kind of injury you strain? Yeah. That's not true. No. You can even do this exercise quite early if you have an hamstring injury strain. I see some physiotherapists. Yeah, even with an injury strain, you can safely do this exercise. But a lot of people get soreness, muscle soreness. And if you have to train the next day with muscle soreness, not nice. If you have to compete, not nice. So a big issue is muscle soreness. But we also know that if you do a proper build-up program with this exercise, I'm a man, I can only do one thing at once. Yeah, here it is. If you do a proper build-up in these exercises, muscle soreness can be quite good managed. But that's just a big issue with this. So what we see is that the adherence in practice is very poor. Another thing is criticism on this exercise is what we call sport specificity of specific movement. It doesn't look like movements you are doing in sports. Yeah, so it's very isolated. But still, it works very well if we look at the data. Any questions from the Nordics or no? No. The new insights. So what do we know further from the recent years? So what we see more and more in research is that exercise and activities affect different hamstring muscles and different regions of muscles. And I will show you in the data. So this is where we want to make sure that you know about different muscles in the hamstring. It's not just one muscle. Is this relevant for exercise selection, also from a preventive perspective? Because we know there are a lot of different exercises for hamstrings. Don't expect you to see all the pictures, but I think also the experienced physiotherapists here, they can make much more slides with all different kind of exercises for hamstring. Most relevant part for now, to make it also slightly more easy and to understand that we can divide it in these hamstring exercises in hip dominant exercises and knee dominant exercises. So just in Nordic, what we did, we call it a knee dominant exercise, but there are a lot of exercises that also can be hip dominant. Yeah. Why is this relevant? What we know now from recent years from studies is that on the different kind of exercise, they affect, and also the activity in the hamstring muscles is different over the lateral hamstring muscles, so the biceps femoris, and the medial hamstring muscles, like the semitendinosus. And if we want to make it black or white easier, is that the more hip dominant an exercise is, the more activity you see in the semitendinosus and also semimembranosus, so the medial hamstring muscles. The more other way around. The hip dominant gives more biceps femoris, so lateral side activity than the knee dominant exercise. So the Nordic, what I did is mainly affecting the semitendinosus group, and if you do more hip dominant exercises, more the biceps group. How do we know this? I want to also show some data from Joep. He's there, PhD, who did part of his PhD was doing a randomized controlled trial on muscle architectural changes. And we compared the Nordic exercise, we compared it with a diver exercise. Who is familiar with the diver exercise? Yeah, you can also try it, very nice exercise. And versus a control group who didn't do any additional exercises. Where did we look at? We looked at changes on MRI, structural changes on MRI. Just to show how these different colors were made in the MRI scan. We can make a 3D image of the different muscles, what I explained about the medial hamstring muscles being the semimembranosus. I think it's in blue, the semimembranosus, tendinosus in green, and the biceps femoris in red. In this new MRI technique, we could image individual fibers, tractography, we called it. And we looked at different architectural aspects. And what we should remember to make it easier, if you want to have an effective intervention for hamstring muscles, an hamstring muscle with long fibers and small pronation angles is less likely to get injured. So sort of those changes you want to see after doing strength exercises for hamstring prevention. So long fibers, small pronation angle. And what did we see? A lot of data, but I want to focus on this one. If you do the Nordics, you see changes occurring in the semitendinosus. Yeah. So what we see here is this was the vesicle length, if I'm right. So doing the Nordics gives the semitendinosus longer fibers, and we did not see this effect in the diver group and in the control group. And doing the diver exercise, so the more hip dominant exercise, we saw changes occurring in the biceps femoris. We saw smaller pronation angles in the biceps femoris occurring, and not in the other muscles. So your exercise selection has an influence on the changes you occur in the hamstring muscle. So what we already knew from previously, you see different activities if you measure with EMG on different exercises, but also with newer techniques you really see structural changes occurring depending on the kind of exercise you do. Is this relevant for exercise selection? Some thoughts from the audience. If you know this, what would you advise your, for example, football player or sprinting athlete to do on hamstring prevention? Both? Yeah, it makes some sense to combine. But also from a therapeutic point of view, you can think about maybe this is a guy who has deficits in hip dominant movements. Maybe we should focus more on hip dominant exercises. Yeah. Both, yeah. There's no level 1 evidence, there's no randomized control trial that shows that doing both exercises is better than doing the Nordic alone. But since I know these results, I'm doing them both. Yeah. Okay. That's also my main message. So you can incorporate both of them, and if you do the diver or there are a lot of other possibilities, you can think about it, of course. Was there a question or some thoughts? Yeah, we're here to share thoughts. Yeah, there's a lot of discussion also within our group, and our hypothesis is that the hamstring muscles is a group working together. We have three heads working together. If one gets weaker, the other muscles also get more vulnerable. So training your semitendinosus will also protect the other muscle heads from being injured. Well, we also, for example, anterior cruciate ligament reconstructions, ACL injuries, they're often used with a semitendinosus graft. Very, very increased risk to get a biceps femoris injury after grafting your semitendinosus. So we think one of the protectors is gone or is weak. Yeah.
You're also working with different mechanisms on different load of arm. So if you're moving from the hip, you only have the upper body moving forward. Different load. As you move from the knee, you have also your the femur is working.
Mm-hmm.
Adding to the load. So is it fair to compare both of them, since maybe one of them is more is a higher impulse than the other?
It's all if you do different exercise, you have different loads. You on tissue. Yeah, you will never.
The difference in effect can be explained by the difference in load or the actual exercise.
I think we have to be careful by explaining. We cannot explain with this research. We only can hypothesize why it works like this. For example, a lot of people indicate, of course, why do we isolate hip-dominant exercise and knee-dominant exercise? An athlete has always combination of doing hip and knee related activities. So there's also a lot of exercise who combine them both. But just to move forward from these classic Nordic, very effective, you should do them, of course. But there is more than that, and we have also evidence that there's more than that, and you adjust and maybe optimize your prevention. Yeah. But why, we don't know. Yeah.
Can I ask one question about Nordic as well?
Yeah.
I know the original researches, and I'm sure you know. Is there similar evidence for the production of injury risk at the professional level? The national research is done with no effect.
Now the study in 2011 from Peterson is in the highest division in Norway. Yeah. There are professional players. Yeah, there are professional players. But of course, if you already do a lot of hamstring strength exercises in your group, why should this extra exercise have the same effect? Probably not. Yeah. I think we have to move forward. There was one thing.
We have 10 minutes, yeah.
We have 10 minutes left. No questions anymore, otherwise there's no time for Anne. Sprinting often is forgotten that we do these exercises, but what we should remember, what we see here is if we look at hamstring activity, and we put sprinting on 100% of activity, there is no exercise in the world that is comparable and ever reach the activity that's reached by sprinting. So what we often see now is that there is a focus on these exercises, but we forget to sprint. And that's what we call a vaccine. Can sprinting be an vaccine for prevention of sprinting-related injuries? Probably there is. There's one research done recently, and they compared Nordic exercises compared to sprinting exercises and just playing soccer. And what they saw is the biggest adaptation in these vesicle lengths, panations, angles is in the sprinting group. Also, if you look at performance enhancement, is largest in the sprinting group. So don't forget that your athlete has to sprint and have to do these sport-specific movements, and not only do exercises and forget maybe the most important part, and that's just prepare your athlete also on sprinting loads. Anne, up to you.
Yeah, I saw some sport shorts in the back, so I'm thinking those
Yeah.
are yours.
Just some.
Maybe we should,
This is
try 'em
just some commercial. If you have guys with hamstring injuries, please call us. We have still studies going on.
Okay. Are there any Star Wars fans in the audience? Yeah? Okay, because as you can see from the slides, we're literally moving to the dark side. Now we're going from white slides to black slides. These are some of the team members that work on this topic. I'm not telling you whose hamstrings these are, but you can figure it out for yourself. So basically, as you know, Guus works with soccer players, and his job in terms of hamstrings is basically very easy, and I'm going to show you why. Thierry Henry here, we all know him.
And he makes a little move right here, and that's
So
when it
sprinting,
goes. You can see,
a
makes
sudden
that
change
cut
of direction,
and feels it on his
a
right
shit
hand.
pass or whatever makes him change direction, and he sustains a hamstring injury. Just grasps the back of his thigh and will probably have pain and palpation, limited range of motion, limited strength. We don't need an MRI for that, at least Guus doesn't. He will know the diagnosis. So basically the diagnosis of a hamstring injury is very plain and simple. So for example, if you look at an MRI image, we can see here the, we call it in the Dutch sitting bone, initial tuberosity. The black one is the hamstring tendon, and the gray area, 1, 2, and 3 are the hamstrings. And if you have a hamstring injury like Thierry Henry in this video, this is a schematic view, this is what it will look like. So next to the tendon, like in a feathery pattern, you will see edema, which is the bright signal on fluid-sensitive sequences. So even if you were to make an MRI, even the MRI would be simple. So then, like this, the quick summary, you would assume that Guus's job on a day-to-day basis is not really challenging, is it? Or is it? Ah, exactly. So, but every once in a while there might be something just out of the ordinary, and this is the part where my job gets easy because you will have to watch a video and tell me what is up instead of the other way around. 2 years back, Sociedad against Valencia. This splitting pass, and then there's Zaza on the right side.
Guedes squares the ball back in. Zaza!
Sorry to say it, Albert, but this is a typical Spanish game because there are red cards all over, as you can see, but also very beautiful goals. Who can tell me where the hamstring happened? And you're not allowed to answer, you, because you know. The goalkeeper, okay, I've not heard that one before. Any other suggestion? So the goal scorer, okay. Any other ones? Referee. You must not like referees a lot. I'll show it to you once more. And let's see if we have some other takers there.
Brilliant ball, excellent run as well.
That's a good goal.
Fresh legs of Guedes squares the ball back in. Zaza!
Any other last takers?
Wow. Yet another classic.
Bram? Sorry? The guy that gave the assist. Okay.
Winner this
Also
week.
possible.
What a great strike, and what a super counter-attack
Right.
from Valencia. Marcelino out of the dugout. There's lots to applaud there.
Yep. Exactly. So maybe Guus's job is not so easy, because every now and then, if we rely on pattern recognition, think we know it when we see it, 9 out of 10 times you're going to be right. That one time you might miss something. And this is something that we thought of in the AMC a while back, because we do research on the proximal hamstring tendon avulsions. So where people tear the tendons clean off the bone proximally. And we found that in a study that we were doing that 1 in 5 patients, that's the 20% on the right, so you guys, was a physio or a doctor with a proximal hamstring tendon avulsion in that cohort. So we thought, oh crap, maybe we're at risk. Maybe if you're a doctor or if you're a physiotherapist, you have a higher chance of a severe hamstring injury. So then we started doing some calculations. If you look at data from CBS, then only 0.6% of the adult population in the Netherlands is either a doctor or a physiotherapist. So then for every 6 physios and doctors we'd be seeing, we were supposed to have 994 normal people. But they weren't there. So we either thought, okay, we're either at risk, which just doesn't sound very logical, or it's just that doctors and physios know their way through the medical system, and a lot of other people that have this injury might be missed. We're not seeing them, or we're not recognizing these injuries. So that's the relationship with the previous video. Every now and then there will be a more severe hamstring injury, and you don't want to miss it, because if you leave it untreated, it will have severe complications or consequences for function and activities in daily life. And this was also interesting, is that the people that was, so this is an interim analysis. On the right side, there are physios and doctors who don't really have a treatment delay, because the higher you get, the longer your diagnosis is delayed. But the group that isn't also had more delay, so that strengthened our hypothesis that the injuries are missed in non-medical professions. So whenever you're in doubt, make sure to order an MRI or refer for an MRI. And this is what you can see, and you can clearly see the difference with the other one. There's no straight black line with a little feathery edema pattern. There's like 2 elastic bands that have been cut, have retracted, and all the white stuff is blood that you can see as a result. So this diagnosis resembles the previous one, but it's slightly different. So the injury mechanism is like the guy that's receiving the ball now. So knee extended, hip hyperflexion, you could say, and then his weight just adds to that, and there's an eccentric contraction, and then one or more of the tendons just go pop. So people have more pain than with a regular hamstring injury. Sitting is difficult because obviously that's where the tendon tore off. Some will feel or hear a popping and tearing sensation, like with an Achilles tendon issue, and there's severe function loss. On the physical examination, which we're going to be doing on Guus just in a second, there will be bruising of the posterior thigh, pain over where the tendons tore off, the ischial tuberosity. There's a palpable defect, which is what we're going to try and see on Guus in a minute, and range of motion and strength are decreased. So I just want to touch on some of the pitfalls, because there are obviously reasons why these injuries might be missed, and I think these are at least 4 of them. First one is the posterior thigh bruising. So this is somebody that came quickly to us, was a physio obviously, and this was after 2 days. This is somebody else, a friend of a doctor, so also came pretty quickly, after 7 days. This is somebody after 10 to 12 days. So you can see that the bruising is migrating distally, and there have been a couple patients that were referred to us with an MRI, which was completely normal, and then had this, if you would ask them for pictures of when the injury was still acute. So posterior thigh or posterior knee hematoma can still be a proximal hamstring injury, even within 2 weeks. We had some patients where the injury was more of a hip hyperabduction than a hip flexion. Can still be a hamstring injury, often coupled with Dr. Lange's or Dr. Magnus injuries, but the hamstrings can still be torn off. Often in a subacute phase, because there's no tension on the tendon and pain has subsided, there will be even increased range of motion compared to the other side. So not having a decreased range of motion doesn't mean that the tendon is or the muscle is intact. And then finally, often in the ER, people are lying prone, and people ask, just flex the knee. You can flex the knee, no problem. Your hamstrings are intact, which is not often the case. You have the short head of the biceps femoris, and you have the gastroc muscles, for example. So sometimes they can compensate and still use their show their knee flexion while it isn't there. So if you're in doubt, think of the coach, think of the one injury that you might be missing, and refer for an MRI and order an MRI. And then I want to briefly show you, for the time that we have left, what the physical exam could look like. Okay. So I'll often have a patient lying prone. They will often come with shorts because they're prepared and they don't want to undress for the exam. Guus, can you move these up a centimeter or 10? And you can get around, it's fine, because this gentleman didn't make the joke about being called Scheuring for no reason, because he actually is missing one of the hamstrings, and I'm curious if you can see which one. So obviously, relax still. So obviously we can see that he has no posterior thigh bruising. Looks like a bite bark, but I will not make any comment regarding that. So what I will always often do is just have people like this and ask them to gently bend the knee. Yeah, that's not a Game of Thrones reference. As you can see, so there's an asymmetry on one of the sides, and then relax this one, Guus, if you want, and do it with this one. You can see biceps femoris No, I'm starting to have doubts. This feels like a semitendinosis, but it's not as clear as it. Oh yeah, this is semitendinosis, and then the semimembranosus will be in the middle, at least distally. And we'll do it on this side, and you can see there's a different contour. This feels quite medial, actually. Can you reveal to us on which side you're lacking one of the hamstring screws?
What's the guess of the audience?
And you're missing the semi-T?
Yep.
Yep. Because often in a different position it will be easier to see some of the tendons pop up. And if we do it on the other side as well, there is something there, but it feels a bit medial. So I'm wondering whether this is either a gracilis tendon or some regeneration of a neotendon after a graft harvest. So this is one of the tests that we'll sometimes do to see if there are any problems. And again, if I do it from the side, if you flex again, some people will have like a defect already visible, especially the subacute ones. So then what I will do, I will tell patients I'm looking for the ischial-tuberosity, and there you can see I'm falling off the bone right here. I have my fingers there, and then I ask somebody to flex the knee, and you see that my fingers are being pushed upwards. If that's the case, tendons are intact. If you feel nothing, you're in doubt whether you feel something, then obviously there's a good chance that it will be a proximal tendon avulsion or a rupture. Or in some cases, if it's a severe but non-full thickness injury, pain will be limiting function. So in some cases where you think it's an avulsion, it's not, or it's a near avulsion. But it's better to have a good MRI with a suspicion than not having an MRI when there is an actual injury. Anyone that wants to feel the hamstrings, who's consented to that? Or anyone having any questions regarding this that we can still deal with even that or over time? I can already see the boss standing there. Okay.
The other room's going over time too.
I think one message with clinical examination of the hamstring is it's no rocket science. You have to do so few things well, and you have your diagnosis or you have your suspicion about a avulsion injury. I think people working in practice, you will see 1, 2, or 3 avulsion injuries in your career. Hopefully you don't miss them. Yes? Yeah, then we are finished, and earlier than the other room.